Good afternoon. We have with us Dr. Brajendra Lakar, Head of the Critical Care Department from the Health City Hospital, Guwahati. We welcome you to the Natco Pharma Specialty Criticon studio. And what we look forward to listening from you is the advice to the younger generation doctors in the space of critical care associated with bacterial resistance. My first question to you, Doctor, is how do you foresee the changes in critical care management?
Yeah, critical care management, if you look back 30 years back, it is becoming more of a machine driven and then of a personal touch many a time. Probably people are moving towards AI and depending upon more machines than probably human touch. That is one thing probably we should be worrying about because we'll have to find balance between these two. So we have to have a clinical touch. The patient has to be well connected with doctor has to be well connected with the patient and they should feel how the patient is feeling and then adapt to that. And definitely AI and the upcoming things are extremely important that helps to target the therapy, to become more specific on our therapy, and individualization will be much less whether the patient is being seen by Dr. A or Dr. C. The treatment will be almost similar if we based on those we get helps from that. So youngsters must get clinically acquainted and they must have very good clinical knowledge about disease and a good feeling about how the patient is feeling because patient, most of them, even if they are half conscious, they have their mind. And regarding resistance, actually discriminate use of antibiotic, is very worrisome. It's not in ICU. So many people get antibiotic before they reach hospital or before they get a disease, because if someone is taking suppose ciprofloxacin 6 months back, the microbiological flora inside intestine will be changing in next 6 months time. It take almost 6 months time to get it back to the normal stage. So the person is already harboring a lot of resistant bugs inside guts. Okay, so that is not the issue in ICU because the people are getting in India, the antibiotic control is extremely poor. Even you can buy from pharmacy over the counter, people are buying antibiotic, they are taking it. That's why when the patient land up in ICU, they are already probably resistant. So we'll have to use antibiotic extremely judiciously. So if someone is exposed to antibiotic in last 6 months time, 3 months time, we should take that history very nicely or a very specific way. If extremely healthy person, athletic, coming to our ICU is a very simple pneumonia, we should not go jumping into the conclusion that he is having resistant bugs inside body. No, he didn't take any antibiotic in last say 3-4 years time. Why we should start a very high end antibiotic? So that's why probably we should look back into our own system and how we were using antibiotic. We're putting everything, we're putting as a disease thing. Like if this person is having pneumonia, these medicines will be okay. But we are not putting into the patient's perspective. A athletic person getting a community-acquired pneumonia, pneumococcal pneumonia, or a diabetic patient who is visiting clinics who took antibiotic 3 weeks back coming with pneumonia is extremely different group. So the choice of antibiotic will be extremely choosy. That's why the future looks difficult sometimes because we don't have any reserve drug and very few in the pipeline. And that's why whatever we have, we must have judicious use. That's what I feel.
Since you touched the subject of AI or technology with the personal touch, um, do you think the technology is really interfering with the personal touch in today's times?
No, we should not over reliance on technology many a time. Like see, if you say the ultrasound, I have say 10 residents in my ICU, and if number one resident is expert on ultrasounds, and he will tell me that these are my findings, and number 10 is I know that he is not expert on ultrasound, his findings may be different. Okay, this is you have a very good ultrasound machine in ICU and two operator, they are operator dependent. So one will have a different is finding, one will have a different finding. So how we operate those machines, the person behind that machine is extremely important. So that's why we must clinically correlate with that, whether it fits into that patient's profile and then come into conclusion. That's why we doctors are there. Otherwise, machine will replace us.
You've already spoken some bit about the next question, but still, I want to go ahead and ask you the advice to the young ICU doctors in enhancing patient care.
Yeah, in the young ICU doctors actually, it's extremely important to be with the patient, not to look at the monitor all the time. You should look at the patient. And many a patient now the studies are coming. Even if patient is sedated, we think that patient is sedated, his brain is active. Whatever we discuss, whatever way we treat the patient, these actually affects his mental state. And that's why the point comes to like how we respond to that psyche of a patient. So a one very sick patient is there in the next bed, and a conscious patient is lying in the next bed. And how we deal with the conscious patient, or how we are seeing the next patient, also affects the other patient. So that's why the youngsters should concentrate or spend some time or more time with the clinical side, bedside with the patient, physically verifying whatever laboratories are saying, whatever the monitors saying. So you should not be very much 100% dependent on monitors. And you should really verify that. And second thing, nowadays they are exposed to so many information. Which information to pick up? Like you may have 100 publications, out of which 90 publications may promote something that this is the way to go. Whether they should apply that in that practice, that has to be choosy, and they should go and verify those things, cross check that, and before application to their practice, they should be 100% sure that this is acceptable by everyone.
I think that's very sound advice to the younger set of doctors. What is the prevalence of carbapenems producing bacteria in your practice, and what is the effective treatments that you can suggest?
Extremely high in our ICU, in like anywhere in India. Suppose if you go by ICMR report 2019, and probably they are having yearly reports now 2022 also, extremely high in ICU. Suppose if someone is staying in ICU for last 5 days, 6 days, then if I get a second infection, 80%, 60 to 80% are resistant to carbapenem.
Thank you so much, Dr. Brajendra, and we wish you all the best. Thank you for spending time with us in the studio.